Setting up meeting for customs training. And we're live.
Okay, Carmen. So we're going to give them 5 minutes, okay?
Oh, sounds good.
Mhm.
So we are live now, right?
Yes, we're just giving them about 5 minutes to get on,
Okay.
and then we'll get started. We need to mute. Dr. Ellis, you can go ahead and mute yourself. Dr. Ellis, your camera is off.
It started now since we're live and maybe someone has tuned in.
Carlene, can we start now?
All right, I think, yeah, 3:04. We have the Jamaican time. Right now it's showing that there are 2 watching, but perhaps others will join with time.
Okay, so we're going to get started. Good afternoon, everyone, and a warm welcome to our Jaminar today. I am Dr. Beverly Frey, chair of the Jamaica Diaspora Health Task Force, and it is my absolute pleasure to introduce our speaker today. A native Jamaican, Dr. Ellis received an Associate of Science degree in nursing from Nassau Community College, Garden City, New York, where he was on the Dean's Honor Roll. He later received a Bachelor of Science degree in nursing from the University of Miami. He then pursued his Master of Science in Psychiatric Mental Health Nursing from Florida International University, where he was a member of the Sigma Theta Tau Honors Program and was awarded the Doris Chavez Cultural Competence Award. He then completed his Doctorate of Nursing Practice degree at Florida Atlantic University, where he was trained in advanced and innovative nursing research, clinical practice, and educational sciences. Dr. Ellis practices as a psychiatric mental health nurse practitioner, as well as an adjunct professor for undergraduate and graduate nursing programs, teaching psychiatric mental health nursing theory and clinical practice. He is experienced in a wide range of adult psychiatry, including but not limited to emergency, inpatient and outpatient, substance abuse, and correctional forensic care. Dr. Ellis has been an invited speaker on the local, national, and international levels and was awarded APRN of the Year by the Mayor of Miami-Dade County. This is in Florida. He is the author of several nursing articles within the field of psychiatric and mental health nursing. His goal is to provide current evidence-based holistic care and service to patients and families using a cultural a culturally sensitive, relationship-based, interdisciplinary, and collaborative approach. According to Dr. Ellis, and I quote, "My overarching goal is to restore individuals and families to their physical, psychiatric, psychological, social, cultural, and spiritual health." End of quote. Please note that we have a technical team on board headed by Carlene Tomlinson, and assisting is Marcia Amarsing, my vice chair, and myself. We kindly request that you write your questions in the chat, and we will feature them and we will address them as we go along. Thank you again for joining us. And I now turn it over to Dr. Ellis, who is going to be sharing his screen in a few minutes and get this thing on the road. Thank you so much. Dr. Ellis, you're on.
You're muted too. All right.
So first I'm going to try to bring the screen up. Okay, here we go. So am I sharing now? Am I sharing my screen?
Yes, you are.
Yes, we can see your screen.
Excellent, excellent. Well,
You can
thank
go slideshow presentation. Go into slideshow.
Going to slideshow, slideshow, and then start
Right.
from, okay.
Mhm.
Well, thank you for having me. Thank you, everyone, and good afternoon. And it is indeed a pleasure to begin this series of educational sessions with you. As Dr. Frey said, we would like your comments. It's despite the fact that we are virtually, we still would like to get your opinion and feedback and questions. So feel free to have them and send them in the chat. The other thing is that we would like for you to ask as many questions as possible, okay? I want to say that this talk and some of the questions and some of the ideas and some of the thought might be relatively new to someone, and it might be for some other people, you might be familiar with it. However, I think it's relevant that we can, share and get an update on these information. So this talk is basically a foundational with regards to understanding certain concepts of mental health, sort of framework where we can lay the future of future conversations. And we will also be doing some basic review of some major concepts that shape psychiatry and how we understand patients from the standpoint of, thought, their mood, their behaviors. And so this, again, is just a foundation for future conversation that we might be having. And with that said, the first screen is to ask the question, what do you think about mental health? How do you see mental health? How do you see people in mental health? What does it look like to you? And, we do have an idea of, especially in certain cultures, that with the minute you mention mental health, we tend to have the idea that, a visionary idea, at least, that someone might be looking dirty or might look strange. In a broader scheme of things, however, mental health at any given time can look like you and I, common people, normal people. So that's this picture is depicting here that, we can never tell what a person with undergoing mental health situation might look like, and that it helps us to remove some of the narratives or the negative narratives or the stereotypes that we might view about people. So it's important that we take stock and start having a different type of opinions and idea about what mental health can look like. Any one of us at any stage can develop some type of mental health condition. So having said that, what are some of the things what are some of the things that influence us and how we see mental health? We would agree that mental health is influenced by, at least how we view mental health, is influenced by a couple of things, such as, our cultures, our values, how we were raised, what experience do we have in life? How do some of those things shape how we view either mental health within our own family or mental health at large? What about religion? What about the education that we exposed to and the life and work experiences? And basically all of these things together tend to influence how we understand mental health. So again, as we go through these slides, you keep that in mind, that there are multiple factors that influence how we see mental health. So again, some of the things that influence us, like we mentioned, influences us, the culture. You have, your patient is at the center of what we're about to do, what we all encounter. And then, so you have all these things, religion and culture and life experiences, having a connection with how we view our patients, how we see them. And understanding that these things influence how we see mental health can help us to kind of take stock of our own internal narrative or our own internal locus of control, our internal worldview. And so hopefully might change some of the ways in terms of the biases or negative stereotype that we might see about patients. So what I also want to do is take a brief historical overview of mental health and mental health care within our cultural system. And, if we go all the way back to, BC, at least 4000 BC, we had the Hippocratic Oaths, and the idea then was that illness, including mental illness, evolves around what they call the four humors. And those four humors were blood, black bile, yellow bile, and phlegm. And the idea then, of course, this was before modern medicine, but the idea then was that people were sick because there were imbalances in these humor, and basically to get you healed or back to health, a series of processes and intervention needs to take place, and one of them was actually bleeding. Then if we move to just about 500 to 1500, a famous hospital in the UK came about. It's called the Bedlam Hospital. I think they changed the name now, but that was a very famous hospital, and a lot of current or modern day movies and ideas and narratives about mental health is framed around this hospital, about how people were treated. Of course, we had the best treatment then, but when you're talking about, people being tied up and they have these horrible, type of restraints and basically how people were cared for. So this hospital in our current consciousness have a sort of, negative stereotype. 500 to AD again, one of the ways they deal with people with mental illness were to put them on ships and sail them out to seas. They were a nuisance to society. So you have the ship of fools. And then it wasn't until the 1600s, then you start having some changes in terms of better advocacy for mental health in terms of Dr. Benjamin Rush and Dorothy Dix. But at the same time, we also had some very horrible things that happened to people. We believe that some of those people who were burned at the stake as witches, the way they were behaving, they may have had mental illnesses. But of course, it wasn't recognized as such at that time. And because we're talking about Jamaica, it's important to realize that, yes, you know, our own Bellevue Hospital was built somewhere in the early 1900s. And it's called Bellevue Hospital now, but I think it was called the Lunatic Asylum at that time. So as we can see this timeline here, you know, there's a lot of changes and improvement. Psychiatric nursing education began in Johns Hopkins Hospital in the 1913, and there was actually the first psychiatric mental health program, education for nurses that began. So where are we now in the 1900s to present? We are at the stage where we call it the decade of the brain. And the decade of the brain basically is the idea that we understand that mental illness is based on a system and based on the idea that we understand about neurotransmitters and chemical imbalances and specific drugs that can help people restore some of the imbalances in the brain. So this is a modern approach to treating mental illnesses. There's a lot of research that's going on in this field right now. All right. So brain development and mental health. If you look at this slide here, you're looking at the neurotuberal development and the various points that you can have vulnerabilities. Most of the vulnerability in terms of, you know, damage to the brain can occur within the first 13 weeks, which is basically the first trimester. And, you know, if you look at week 3 to week 10, you have neural tubing formation, basic brain region formation, and it goes along. The takeaway from this slide is that this is a very sensitive area, and this is a very sensitive time for human development. And any stress factors that a mother goes through during this time can definitely influence the outcome of the child. When we see patients with mental health condition, it's very important that one of the things we try to understand is what was the environment of the person, especially if we're looking at young children. And when we say environment, we need to go back also in utero. So if a mother is very stressful during pregnancy, experiencing emotional, physical abuse, there's a lot of stress hormone that can go out. And within these, and of course, talking about drugs and alcohol, a lot of these stress hormones can affect the unborn, and the earlier that they're exposed to these things is the worse the outcome. So the takeaway from this slide is that during pregnancy, that environment needs to be protected from external and internal excessive stimuli. because it can have negative outcome on the newborn baby. And sometimes you will not see some of these negative outcomes immediately. Drugs and alcohol, you may see it right away. Other type of traumatic events, you may not see it until maybe 7, 8 years old. And some other stressors maybe later on. So mental health across the lifespan develops at different levels, and there are different conditions. Some of them are short-lived, some of them are long-lived. And if we look at this timeline in terms of from younger years to older years, most of the child and adolescent condition, for example, autism, you will see expression of that at a much younger age, sometimes between 1 and 3. And, mother will say baby's not interacting, not stimulating. Baby is not, meeting some of their milestones. So we kind of take stock of these things as the infant maturate through the different levels and these different stages. If you look at things like illegal drug use, I've seen patients now that they're using drugs from the age of 12. Okay, attention deficit disorder, that usually starts maybe between 5 to 7. That's when it's usually diagnosed. And depression, you can see depression in children from as early as 3 years old, 3 to 5 and on. So it's very important here for us to really pay attention to our kids and know what is normal, know what normal milestones are. And so we have a better chance that if they're not meeting milestones, then, we can at least get them evaluated. Schizophrenia, believe it or not, will occur, depends on the amount of genetic loading that they have. Schizophrenia can start as early as around 15 years old. So the standpoint or the marker for schizophrenia in terms of average is around, say, 18 to 25. So that's around the median age, but we do see it happens much earlier and it can delay much later. So it depends on the protective factors or the protected environment that the person is in. The more stress your environment is, the quicker the expression of the illness will occur. The more stressful your environment is, such as drugs, alcohol, unstable environment, adverse childhood experiences, such as abuse, neglect, you will see the expression much earlier. And so, sorry, go back here. And of course, dementia, things like dementia, you're going to probably see that a little bit later in life, okay? So how are these complexities and the timing occurs? Some conditions are very complex, but easily addressed and eliminated. So for example, delirium. Delirium is a time-limited condition where it's usually occur as a psychiatric presentation, but really it's a medical condition. Usually some interruption in the sensory system, For example, it could be a medication that the person is taking, or it could be an environmental changes, it could be infection. And it comes on very, very rapidly. And the person behave as if they're having a psychiatric problem, disorganization, confusion, and all that. But it's short-lived, because once we treat the medical component that causes that, then it usually go away. But we do have people who have psychiatric, such as, psychotic disorder, and on top of that, they can have acute delirium. So we just have to watch that also. So things like anxiety is very, very chronic. It could also be time limited as well. It depends on the nature of anxiety. So if the person is having an acute anxiety specific to something about maybe trying to get things up for this presentation, you can get a lot of anxiety, but that anxiety is sometimes can be productive, because it helps us to be alert and prepare for things. But there's another type of anxiety that is sort of chronic, and this unspecific in terms of cause. The person can't tell you what's causing their anxiety. They're just very anxious, and some of that are genetic as well. So it's very important that we understand that a lot of psychiatric conditions can be genetically linked. Things like conduct disorder that usually happen can be time limited also, but then it can also progress into something else. So conduct disorder is like the precursor to, so other sociopathic type of behaviors. Depression is chronic, usually. Again, it can also be time limited. Other conditions like bedwetting or having problem controlling your bowels and your brother, like enuresis or encopresis, depends on the stress, depends on the environment that the person is going. It can be time limited or it can be chronic. But there are some things that are very, very chronic, and those are mostly the major conditions, the major psychiatric disorders. Attention deficit disorders, bipolar, personality disorder is very chronic. Dementia is chronic, usually starts later, but it's very chronic. Any kind of intellectual disability, and of course, things like schizophrenia and a schizoaffective type of condition. Those are chronic and severe. So let's ask a question, and of course, we're not able to answer, but you could write this answer down. It says, as a mental health care professional, what theoretical concepts or framework that guides how we understand patient? So I'm a big proponent of using theoretical framework. Theoretical framework helps us to helps us to understand the person's journey, what happens to them during the course of their lives. What are the obstacles? What are the different systems or the different components in their lives that, whether it's family, whether it's environment, and there are all these concepts and ideas that you can use to understand and help them understand themselves. So everyone know about Sigmund Freud, and of course Sigmund Freud was from the 1800s in Austrian neurologist, and he's the founder of psychoanalysis. And his methods of treating pathology such as neurosis and psychosis, he really believes his ideas sort of blame the mother for a lot of things. And, of course, a lot of people disagree with him at the time, and a lot of people did agree. And so, but his foundation, his framework still holds very, very relative today in terms of understanding a lot of things. So in terms of these developmental theories, when they begin, or we can go further from the 1900s, but, it's begin with between 1900, 1910, Freud, Adler, Albert Adler. These are all theoretical experts, theoretical framework analysts, psychoanalytic theory, personality theories. Some of them are like Adler is a neo-Freudian, which means he kind of break away from Freud and then but use other ways of explaining the psychoanalytic type of understanding. We talk about Carl Jung, neo-Freudian, Sullivan, interpersonal theory between people, Erickson. He's also psychosocial development. B.F. Skinner is a behaviorist. So we're familiar with a lot of the behavioral researchers that were around. Bandura's social learning theory. Piaget, cognitive development. Huge now for us, what we're using now. If you work with kids, you're using a lot of behavioral theories approach. If you're working with people with a lot of depression and a lot of anxiety problem, cognitive behavioral therapy is evidence-based now for using. Then we go to Maslow, which is the humanist, and basically Maslow said, that, people needs to have this sense of security and safety, and they need basic things like air and food. I always remind students in the hospital, patients, not uncommon for patients to come into the hospital, to the emergency room, because it's cold outside or because they're hungry. And instinctively, they recognize that if I go to the emergency room, they will feed me, or I can sleep maybe for the night. Now, a hospital doesn't function that way. So we have to be able to understand and balance how human needs are driven versus, how we approach or how we re-guide those people. So, we call people revolving doors, we call them a lot of negative names, but if we understand what Maslow is saying is that these people will come to you if they're fearful or they're hungry. And it's not a criteria for keeping them in a hospital, but we can still help them and guide them, maybe guide them to a shelter or something. Carl Rogers is also another humanist, and Carl Rogers is basically interpersonal. So a lot of the some of our nursing theories build their concept on Carl Rogers. And Carl Rogers is this person that will just, very empathetically listening and taking notes and, doing a lot of what we learn in nursing school about active listening. And, that's a huge concept there of how to do that. So this is a whole special techniques there that he would use. And if you can, get a hold on it, get this concept down and practice it, you'll see how rewarding it is. So a little bit more about some of the work that Freud did. We're probably familiar with the structure of the line of the mind, and we're familiar with the powers of the ego, the superego, and the id. and basically that the ego is the self and mediate between the id and the superego, and is part of our personality structure and how we communicate with the world. The ego is slowly developed over time as we, from birth to, maybe adolescent, young adults. And it focuses on that reality principles. This superego basically is your conscience, okay, right or wrong, rules and conduct, unconsciously laden. And the superego is very important because it balances out the id and, basically redirects the id. The id is unconscious and it's driven by urges and immediate needs, have no sense of, self-control. It drives us to primitive instinctual drive. So the id will allow you to do things that you might regret later if you don't have a good superego to balance it out. Why do we, realize that, I need to behave in a certain way, wait for appropriate time to do something? Some of our patients, though, if they're very psychotic or they're very manic, they will lose some of these functions and they may do things that we might find appalling. But we have to remember that it's within the context of maybe they're not having a good ego strength. Ego strength, ego development. You can have people ego syntonic versus ego dystonic. A person who is ego syntonic, they will integrate what the id says and feel very comfortable with that and does not recognize the consequences that could occur. The ego dystonic, however, will recognize that what I'm thinking and what I'm feeling is not right and I need to change it. So I'm not incorporating that into the consciousness. Okay. So you have conscious, you have pre-conscious, and you have unconscious according to Freud. And these are embedded in the consciousness. So you have conscious ideas, which are thoughts and feelings that we are aware of within the moment. You have pre-conscious ideas, thoughts, and feelings that we can bring to mind, and that they're just below the surface and they are available. So if we think hard enough, we can reach in and bring back even things that we are not remembered. Sometimes we get the stimuli like music or a smell or something, and these can bring back some of that. The unconscious, however, they're deeply embedded way below the surface, but they cannot be brought back to this surface on a voluntary basis. So a lot of times we might need assistance such as you put your hypnosis or something and maybe can activate some of these. And there are sometimes very, very disturbing thoughts and ideas that dwell in this place. And it's not safe to bring it out unless you have the protective mechanism to deal with it. So this is a busy slide, but I'll try to just kind of walk you through. This is the theory and practice timeline. How do we get to where we are now? And we start back in, say, from 1906 with Pavlov, and he published his studies on classical conditioning. And we all know about Pavlov and the dog, okay? Every one of us who took, psychology in class, we learn about that. And then Carl Jung, and he departed from a lot of Freud's ideas and theories because he believes Freud was too sexually oriented. 1900, back now in 1910, Freud again, he began to perform theory. Alfred Adler leaves Freud and start his own business. In the 1920s, Piaget began writing about cognitive development. And 1930s? So if we're talking about treatment, so treatment for psychiatric illness didn't begin with medication. There were insulin, shock, some of the other things that we didn't put on here. There were what they call ICE treatment. Can you imagine giving a person a high dose of insulin and put them like in a coma and pack ice on them? ECT began use within that same time period. And ECT was a lot more dangerous then than it is now. We still use ECT now, but it's at a last resort. And of course, it's much more humane. Lobotomy, another common practice. And basically, this is when they thought the part of the brain that was causing a problem could be located and removed. So they would bore a hole in the brain and they would remove a certain part of that brain. And we know some prominent people, such as the Kennedys, some relatives of the Kennedys in the United States actually had lobotomy. A lot of them were left permanently disabled from that. Carl Rogers' 1942 published book about his new approach to the humanitarian theory. What else is happening? So medications start to be used in 1952. First set of medication that came out, Thorazine, is an antipsychotic drug. Thorazine was actually discovered by mistake. They were looking for something to treat malaria, if I remember correctly. It may not have been malaria. It may have been anesthesia, one of them. I remember one of the drugs is for malaria and one was through in exploring anesthesia, but whichever, they realized when the patient woke up, they were a lot more calmer. But and then you have some other theories. Skinner is using his behavioral works there, and Maslow's. But look at the DSM, 1950. So I'm not sure in Jamaica whether we use the DSM or we use the ICD, but the DSM came out, the first print was in 1950, and that was the book that kind of helped to define mental health, describe a mental health condition, put it in an organized manner, and outline the criteria for making the diagnosis and attach certain codes to it. And that was the DSM-5 1. And just about every 10 years, this book is revised. So we're currently using DSM-5, and just within the past month, so the DSM-5 came out in 2013, and just in the past month, we have a new revision, which is called the DSM-5 TR, which some modifications were made. I'm pretty sure a lot of us know about Hildegard Pepler. Hildegard Pepler is considered the guru of psychiatric nursing. And she came out with her first theory in 1952, and actually Hildegard Peplau took a lot of her work. She was actually an understudy with Carl Rogers, and she is all about relationship-based care. Okay. More medication came out, like imipramine came out in the 1950s. Haldol came out, Thorazine 1952, Haldol 1959. Bandura came out with his research, 1963. Those of us who do group therapy, we need to know about Yalom, 1970, very fascinating. Lithium, in terms of treatment, was around 1970. And we can see here that the DSM number 2 came out 1968. And here we are, 2013 DSM-5 came out, and now we are up to DSM-5 TR. So you can review much more of this. SSRIs came out. SSRI means selective serotonin reuptake inhibitors. They're antidepressant medication. They came out in 1988. And that revolutionized how depression is treated, because the old medication treating depression, they had a lot of very bad side effects. So just as a refresher here in terms of understanding some of these theories in a little more in depth, you know, you have Freud psychodynamic theory, and basically focusing on insight, intrapsychic conflicts, anxiety, and defense mechanism. We know about, whenever we learn about defense mechanism, is based in Freud, and there are a lot of defense mechanisms. Some of them are primitive, some of them are high functioning. So you can go through that. One of the things that it's part of our working model and working understanding that derived from Freud is this whole thing about transference and countertransference. So transference is when the patient has feelings and thoughts toward us that reminds them of somebody in their former years or their former life, and they see you, the provider, and they are transferring some of those feelings onto you. Those feelings can be either good, they can be bad. And then the countertransference are when us, the provider, the therapist, see the patient and we start developing feelings, attitudes towards them. There's nothing wrong with having these feelings because they are unconscious, and we really can't help a lot of times experiencing these feelings. What is important, however, is that we know how to recognize them and do not push them aside or run away from them, but actually work through them. We need to be able to recognize, identify, and work through them. And there's a lot of strategies and work, work series that we can do to kind of teach people how to do some of these. But the main thing to know is that it is not bad to have those feelings. We cannot control thoughts and feelings that come into our mind. What we control is how we act on it. So with these transference and countertransference, you know, we have to be careful that we don't cross boundaries. And it depends on what, you know, society you're in. So in the United States, the boundaries are extremely, extremely strict, the professional boundaries. You know, we can't share personal information with patients. We can't, give them a lift in our car. We can't buy them gifts, and we can't accept gifts from them, and all of that thing. It would be interesting to know, somebody could maybe talk about that in the chat, is whether in Jamaica, whether or not this is a concept that's talked about in practice, and how do we see that? Again, Sullivan, he is the interpersonal theorist, and he's focusing on interaction between individuals and their own environment. And again, he talks about how the personality is influenced by their social interaction and biological factors, okay? And anxiety is the motivator of human behaviors. Anxiety is a very important thing to understand beyond when a person just say they're anxious. So anxiety is basically the root of a lot of psychopathology. And people will be full-blown psychosis, but their presentation is anxiety. People will, before we see a person in full-blown psychosis, they may be having some form of anxiety 3 to 5 years before. And hence some of the arguments now. So for example, people are using drugs, they get hospitalized because they're using drugs. But when you really do an assessment, the drugs was initiated to kind of help with anxiety and restlessness and sleep problem that they've been feeling as a precursor to something like psychosis or mania. Hildegard Paplow, we mentioned her. She is the guru for psychiatric mental health nursing. Every psychiatric mental health nurse should know about Hildegard Paplow, and she developed the relationship-based care. And I probably invite you to kind of just read up on her concept there. Some more of these theories. Of course, we talk about Erikson, and Erikson is another one of those gurus that to understand developmental, especially from birth to death, we always fall back on where is this person at within those stages. And that basically Erikson, to understand about what Erikson is saying is that if any one of those stages is interrupted, the person is not able to maturate beyond each one, basically you're stuck. So chronologically you can go on, but functionality or the way you think, you're basically stuck in that. And it can have severe consequences, pathological consequences throughout your life. So that's very important in terms of we need to create, when we're educating parents and caregivers, when we're educating families in terms of building their family system, and because they might have children and then they might have older relatives, we need to re-educate them about what each one of these stages meant. Uprooting a person who, in their late stages gerontivity, and they have to adapt to another environment can be very hard and can be very detrimental. There are common talks about, we the diasporas, trying to get our families, say from Jamaica, to come live with us. And in a lot of cases, they end up dying much faster because they're used to their own way of life, even though they might be poorer and don't have luxuries like we have here, but they're very settled in that kind of environment. And they know their neighbors, they know where to go. And if you bring them here and lock them up in a house because you have to go to work, and then you give them all these warnings about don't open the door because it's not safe here and all that, they really deteriorate. So we think we're doing good things for them by having them with us, but they end up being isolated anyway. So, along that line, we can see how they can lose developmental, growth, lose some of those things that they're supposed to be achieving as they go along. Cognitive theory for Piaget, he talks about basically mental function and organization and assimilation. That can apply also to cultural adaptation and all that. And Ian Pavlov's, that unconditional stimuli. All right, we'll move to, for time's sake, we'll move to some more B.F. Skinner and token economy. If you're working with kids, if you're working in a behavioral setting, we know about token economy in terms of behavior management. Maslow, we talk about, is the humanist, and basically is the person need to achieve a sense of security. Rogers, psychological reflection and listening, and empathy help people to gain self-understanding about themselves. I would advise her to, maybe go on YouTube. Maybe go on YouTube and watch some YouTubes on Carl Rogers. There's a very popular one called Gloria. And, he basically, how kind and gentle and how empathetic he is. And you can use some of these approaches to, take care of, interact with patients. What, the next slide here is the attachment theory. Very important in terms of growth and development and kids from a early age. And we know about John Bowlby. So most of us are aware of the famous experiment that he did. And what he did was trying to determine, he experimented with baby monkeys, and he wanted to determine what makes people satisfied and nurtured and safe. So he designed if you're familiar with the net or the kind of wire kind of figure, and sort of representing a mother monkey. And one of the wire, he designed two pieces. One wire, he stuck it with, like a bottle of milk. And then the other wire had no milk, but it was covered with very soft cushion. And the monkey had a choice of which one they would go to. And basically the monkeys, every single time they rejected the bottle with milk and they went for the cushion wire. And what that is saying is that that period of time, small kids, small people, infants, that period of time is so delicate that the most important thing is actually not food, but is to feel secure, is to feel nurtured, is to develop trust, is to have the ability to self-regulate. And I think this is, when we look at how we raise kids nowadays, kids needs to be raised in an environment where they can feel trust and comfort of, coming to parents or caregivers and, ask questions. At the same time, they can be allowed on a gradual basis to make some choices on their own. And so they develop in, much healthier, secure individuals in adult. So if they're not able to experience healthy attachment, they can be an insecure individual, or healthy attachment can be a secure individual. They can be a very anxious, or they can be very disorganized. So parents' early attachment experience, the infant form attachment, and then, the parent's reaction to the attachment, and the infant attainment or attachment of the positive attachment styles, so to speak. And he talks about things like pre-attachment, indiscriminate attachment, discriminate attachment, specific attachment. And these are when, basically when the child is from, a couple of weeks old, they show particular favorites of who they would want to go to. And at a certain point, it didn't matter as they gained very trust because they know parents were there. They could wander off a little bit and come back. We talk about learn about the peekaboo phenomena where, they can go hide and trust that we're there because they establish that secure attachment. So see how much time we have here. So just a recap in terms of theoretical concept of care, we have Freud, and then he talks about in terms of development, you have the psychosexual development from Freud, and it from the oral stage, phallic stage, and what happened during those different stages. You have the intracyclic conflict, neurosis and psychosis, phobia. And this is basically Freud's idea at these different stages. So you can just review these. Then Erikson, his developmental theory starts with infants, birth to 8, early childhood, 18 months to 3 years, the play age, school age, adolescent. And if we're familiar from nursing school, we know about the trust versus mistrust, autonomy, shame. And we need to be very careful that, people go through these stages without interruption, because they can have major life complications from a psychological standpoint. Sullivan's developmental concept, he talks about from infancy, childhood, and the different levels there, pre-adolescent, adolescent, but he talks about the theory from the oral gratification and anxiety state, delayed gratification, forming peer relationship as they grow, same-sex relationship, opposite sex relationship, and self-identity. And just to highlight, same-sex relationship does not mean same sexual relationship, but that kids will bond with same sex at a much earlier age in terms of play and friendship and all that. And it was later on that when they get older, they would branch out to more opposite sex. So some other theories, we touch base on and Maslow's, and again, his hierarchy of needs, focusing on survival, love and belonging, self-esteem, self-actualization. This is very hard to achieve, self-actualization. Very few people are actually able to do that. Then you have the health belief models. Basically, what are the things that people do or within their society that cause barriers to care, for example, so susceptibility, diseases, seriousness of diseases, benefits from health, barriers to health. Most of us by now probably learned about the trans-theoretical model of change, and we use this mostly in population dealing with substance abuse. Very good model, because we tend to have the idea that we need to tell people what to do, those people who are experiencing substance abuse, that we need to kind of hit them over their head with, a hard club and tell them they need to stop. But rather, if it's basically a working understanding, and the person is going to decide where they want to start, how they want to start, and then we accept that and work with them. So if they're in pre-contemplation stage, they are not ready to get help. Contemplation, they may be started to say, I will think about it. Maybe ask you for some information, like some pamphlets. And then preparation is when they're actually taking the steps to maybe go to a place and get an appointment or something, or just to get a sort of more information about how they need to approach it. And then the action is when they actually got into a program, for example. And from that, you have the maintainers. How do they maintain themselves throughout? But then you cannot actually have relapse. And relapse is not what we want, but it's expected. So when it happens again, we just embrace them and tell them that to start over. Motivation interviewing is a spin-off of the trans-theoretical model. And this is another like empathetic type of approach where basically the person may have been struggling with, the decision to make changes. And basically we meet them where they're at, whatever decision they want to make or they feel comfortable making at that time. We embrace them. Okay, so based on it's based on the same theory of change, and it's goal directed. You tap into the client's motivation. They do have the motivation, but they may not want to start ideally where we think it is. It's non-confrontational. So, my patient will say, I know that I have a problem, but I don't want to take medicine. Okay, I will come back and talk to you, but I'm not taking the medicine. Well, some people would say, well, I give medicine, and if it's a waste of time if you're not going to take medicine, you don't need to come back to see me. So motivational interviewing said, of course, have the person come back and then talk some more. Maybe it might take them maybe 5 or 6 times coming to see you before they decide that they would. Or maybe they might say, I'll do a therapy, but I don't want medication. So speaking of theories, we can't do that without including some nursing theories. And I wonder how much of us are familiar with the different nursing theories. There's a lot more that's on this screen. But of course, a lot of us are familiar with Florence Nightingale. She was never a theorist by design, but she became one in terms of her insight into making the environment safe. So she's more of an environmental theorist. And we have people like Betty Newman. Some of my favorites are favorite in terms of applicability. They all are, but I ascribe to Peplow a lot. I ascribe to I'm trying to look for her name now. I like Martha Rogers also. And self-care is Orem. Where's Orem is on here someplace. Orem self-care. But all of these nursing theories are, very important, and they're specific. You can apply them to patient care in a specific situation that they're going through. So I would applaud you to start looking at theoretical framework in terms of taking care of your patient. Madeline Leininger, cultural care and diversity. Now, we might say in Jamaica, we're kind of a semi homogeneous culture, but not necessarily. I think we're in a very mobile society. I'm sure there are a lot of people that we might get into a healthcare system that probably not natives. Okay, so we just need to be aware of that. And I would like to get your comments on things like that. How are some of these things being played out in the island? And I think my last slide here is this one. And so this is a list of some very prominent people, and I'm sure that you probably can identify some of them. I thought it was fitting to add Mary Seacole. She's not a theorist, but she's a very strong historical figure. Of course, Nightingale, and we all know that Mary Seacole met Florence Nightingale in the Crimean War. Mary Mahoney is, keep clicking on this thing. Mary Mahoney was the first registered nurse in the United States. I tried to find who was the first registered nurse in Jamaica, and I couldn't find it. So maybe someone can look that up. Hildegard Paplow, we talk about interpersonal, that's the guru for psychiatric nursing. And Martha Rogers, Unitary Human Beings. I put Faye Abdallah on here because I actually met her in person. When I was doing my master's, we had to write upon a theorist, and she was alive and working at the Army Hospital in Bethesda, Maryland. So we drove up there and interviewed her. That was fun. And this is Dorothy Horam, self-care, and Madeline Leininger, cultural care model and adaptation model from Sister Clarissa Roy. So of the many, many, many nursing theorists, just a snapshot here. So in putting this together, talking about a concept, if we have an idea or a concept, patient is always the center of care. And how do we get from concept to conceptual models? We have an idea, and then, you can take that idea in many, many directions. So, a conceptual model is a set of relatively abstract idea. How do we understand this concept? Okay. Or you can have a theory, which is one or more concrete or specific concepts that are derived from a conceptual model. So you have a concept, you can go either here or here. They're all interconnected. Conceptual model in nursing provide explicit orientation for nurses and other healthcare providers. We need to identify specific purpose and the scope of nursing that we're doing. And again, because the patient is at the center, because whatever we discover needs to go into improving outcomes, which is improving patients' care. The function of conceptual model is to provide distinct frame of reference, and function of theory is to basically narrow or more fully and specific and specified phenomena that contains in the conceptual model. Okay. So, if we want to do research later on, we need to have some of these ideas in mind and how they work. So I thought I'll just put that there to have you thinking. So at this time, I want to welcome if there's any questions or comments that we could need to stop sharing this screen.
Yes, please, Dr. Ellis. Thank you so much for a very informative presentation. We have some questions for you. The first question comes from, I think, Ms. Dillon. And her question is, how can teachers help students with trust issues as their parents go through divorce?
Right. How can teachers help students? I think I would say that one of the first things to try to impart on the student is that this is not your fault. Mommy and daddy's having some disagreement, and this is not your fault. A lot of students, a lot of kids, they internalize situations like that, and they tend to blame themselves. And I think it's important that they feel that this is between mom and dad, and that it is not their fault, and that they can feel trusted of that teacher to share whatever they're feeling. I think it's important that they develop that trust, because if they come to you, you cannot violate their trust. So and you might have to let them know that what you're telling me, it's between you and me, but there are some limits. If something happened to you, I might need to share that with authorities. So we have to be very careful that we don't say, I will not tell anybody anything.
Especially when it comes to life and death. You have to
life and death and vulnerability on, any kind of abuse or anything like that.
Exactly.
Yeah. It's a very difficult and very delicate situation, but at the same time that, they need to feel that they can come and share.
Yes. And thank you so much for that. And then we have one more question, and I forgot who this came from, but it says, what % of adults achieve self-esteem versus self-actualization?
I don't have the percentage, but self-actualization is so high. I always, when I teach students, people like self-actualization as reached by, say, people like Gandhi, people like
Teresa.
Mother Teresa, Nelson Mandela, people like that, who really, really struggle and struggle through life. and beat the odds that kind of way. But we all are working towards self-actualization. All of us are working. We want to reach the point where we can retire comfortable. We want to reach the stage where, you know, we don't get depressed. And that's some level of self-actualization. But in that self-actualization, in terms of that, it's such a high bar. We can only keep working on it.
Oh, by the way, that question came from Island Girl. Island Girl, thank you so much. And Dr. Ellis, just to let you know that there were some compliments regarding the theoretical, regarding the information you gave about the theoretical underpinnings of nursing, especially, well, psychiatric and mental health nursing. That was very in-depth, and we appreciate that. In fact, I myself am a nurse, and Marcia, I know, is a nurse. And so it took us back to the days of psychology, nursing. So, you know, when especially Maslow was one of my favorite theorists, and Dorothy Oram, self-care.
Right.
So yes, that was quite in-depth.
They're very applicable. They're easily to apply in patient care, and that's why. And if you're in psychiatric nursing, it would be PEPLAU, easy to apply.
Mm-hmm, mm-hmm. Marcia, do you have any questions? Do you have any comments?
No, I don't, but I just want to say thank you, Dr. Ellis. It was very in-depth. Mm-hmm. I didn't even expect that I would learn so much from you, but I did. So thank you again.
My pleasure.
But we have to remember that he's a professor also. And and this was geared mainly towards nursing and health and other healthcare professionals. So it was a bit heavy on the theories and so on, but I'm sure being a nurse and any psychiatric or mental health professional would really identify with this. And we hope that you learned something and you have come away better than when you came in.
And the idea is that the future discussion that we're going to have will draw on some of these. So exactly. This was sort of like a framework, right, that will always draw on when we talk, even when we talk about the disease processes.
Exactly. This is where we started from, the foundation. You have to lay the foundation before you can actually build the house. And I think Dr. Ellis has ably laid the foundation today. So we have a solid ground to move forward on. So thank you all very much for participating today, for joining us on a Sunday afternoon. We know it's very, very special in Jamaica, but we hope that you were able to glean some information that you can take into your practice. Thank you again. We appreciate your time.